Objectives for today's session are to focus on health disparities and the racial and socioeconomic impact of them on them and how these are associated with systemic racism, and then focus specifically around COVID-19 to give you a prime example of a health disparity that is unfolding before our eyes. So, just to get started, disparities essentially exist if health outcomes are seen to be at a greater or lesser extent between populations. Disparities are usually associated with race or ethnicity, sex, sexual identity, etc. And I'm not going to read all the details, but it should be noted that socioeconomic status is also one of the factors that can be related to disparities, as well as geography. All of these at the end of the day can contribute to whether someone is achieving optimal health. And it's also important to recognize the true impact that social determinants have on health outcomes. On the right-hand side of the screen, what you see is a graphic that essentially provides an overview of the county health rankings concept that was developed by the University of Wisconsin's Population Health Institute, which essentially says if you were to look at the health outcomes for any population, which can really be defined by how long people live and their quality of life, you can divide the factors that influence those health outcomes into basically 4 categories. And if you think about healthcare, it represents about 20% of the factors. That is, do you get access to care and do you have access to quality care? Your health behaviors, do you drink, do you smoke, do you exercise? It represents about 30%. 10%, however, of the factors are really focused on your physical environment. Where do you live? And then 40% can be associated with socioeconomic factors like your education, your income level, your job status. And this is important to note because often in healthcare environments, we get so focused on the healthcare component that we fail to realize the importance of really looking at the other components. So what are health disparities? Essentially, they are the differences that are closely linked with many of the factors that I just mentioned. They adversely affect specific groups of people who have systematically experienced obstacles. And we're talking specifically about health today due to their race, ethnicity, religion, socioeconomic status, etc. They are often preventable differences. When you think about the burden of disease or injury or violence, they are preventable differences that really interrupt a person's opportunity to achieve their optimal health. In the graph on this page, although some of the data originally that was put on the graph is a little dated, the unfortunate part of this discussion is that many of these disparities remain. When you think about stroke and cervical cancer, there are still, and infant mortality, there are still significant differences between populations based on race. So why is it that we would even think about focusing on health disparities? Why is this important? Well, let's start with some basic demographic data. At the end of the day, our country is changing. The demographics of our population is changing. If you look back to 2016, about 40% of the population in this country were people of color. Fast forward to what is projected for 2050, over 50% of the population in our country will be people of color. Why is this important for us to think about? If you go back to the previous slide and look at how disparities are captured in our country and the disproportionate impact on various populations, especially people of color, we should all be worried, because what we will see if we do not change some of these trends is an increase in negative health outcomes for a larger proportion of our population. So let's shift specifically to COVID-19. This has provided us with an opportunity to really watch the unfolding or the development of a new health disparity right before our eyes. So if you think about some of the core data related to COVID-19, globally, there are over 35 million cases and over 1 million deaths. In our country, over 7.5 confirmed cases and over 200,000 deaths. These are staggering statistics and very, very concerning. But what we also know is that behind this data are some very, very disturbing stories and statistics. So let's come home to Virginia. Now, when COVID-19 first unfolded, we were all very focused on the impact on our senior population. And even today, as we look at what is happening in regards to this pandemic, the vast majority of individuals who are dying as a result of COVID-19 are individuals who are 70 and above. And that is both at the state level, at the local level, and across the country. However, what is very interesting is that when you look at the distribution of the cases, we are now starting to see a shift in an increase in cases in younger populations, specifically in the 20 to 29-year-olds. Now, while the risk factors are much lower for the 20 to 29-year-olds, we are seeing significant increases in the cases. While the death statistics are not reflecting directly with the prevalence of the disease, it still raises the question of, shouldn't we all be concerned, because what we're looking at is a preventable trend. Very interestingly, somewhere around mid-April, March to April, we started seeing some publications that brought up this issue of, is COVID disproportionately impacting populations outside of our seniors? And our public health officials began to publish to really raise the awareness as they were collecting data that showed us, not only from an age perspective, but from a racial and an ethnicity perspective, that there was something else behind these numbers that we needed to be concerned about. Some of the most recent data that's come out of the CDC has truly confirmed that there is an issue that we need to be thinking about as it relates to how COVID-19 is impacting Brown and Black individuals in our country. This chart basically shows that when you do a comparison on Brown cases, hospitalizations, and deaths, what you see are disturbing statistics. Whereas American Indians and or Alaskans or natives have 5.3 times higher the hospitalization rate than whites. African Americans, 4.7 times higher, in our Latino population, 4.6 times higher than whites. Also, when it comes to cases, you can see the disparities across people of color versus whites, and also from a death perspective, 2.5 times higher for African Americans than for whites. These are all disturbing statistics As we think about the communications activities, the efforts that are underway to try and help prevent the spread of the disease. When you think about what is happening here in Virginia, we've had almost 152,000 cases since we started tracking the pandemic. What's also interesting is that from day one, we were not tracking cases by race and ethnicity. So we have a lot of data or a lot of cases for which we do not have data. And it became so disturbing that in early May, the Commissioner of Health sent a note out to all healthcare providers that basically said, we need you to capture this information because of the trends that we're starting to see. But essentially, what we know today is that when you look at the data for Virginia, what we are seeing is that it's disproportionately, or this pandemic is disproportionately impacting Black and Latino populations, as we are seeing similar trends across the country, with African Americans making up about 20% of the population in the Commonwealth, but represent 25% of the cases, 31% of the hospitalizations, and 27% of the deaths in the Commonwealth of Virginia. In regards to the Latino population, 10% of the population identifies as Latino or Hispanic, while this population represents 29% of the cases, 28% of the hospitalizations, and about 10% of the deaths. Bringing it closer to home, when you think about the city of Richmond, about 4,800 cases and 62 deaths, but similar statistics as what we've been seeing in the state. For the African American population, about 48% of the population identifies as Black or African American. However, represents about 41% of the cases. Okay, that kind of in line with the population. However, 60% of the hospitalizations and 53% of the deaths for City of Richmond residents. For the Latino and Hispanic population, even more disturbing in regards to disparities. While our Latino and Hispanic brothers and sisters represent about 7% of the population in the City of Richmond, they represent 33% of the cases, about 27% of the hospitalizations, and 13% of the deaths. Again, right before our eyes, we are seeing disturbing statistics. As the team at VCU Health System has watched what has unfolded at the national level, the state level, and the local level, we began to think we really need to step back and take a look at what's happening within our health system as well. And this is the most recent data that comes out of a tracking report that we have put together that basically looks at the demographics of the VCU health population that is impacted by COVID-19. As of yesterday, we had over 735 admissions since we started tracking this data in March. About 55% of the individuals have identified as African American, but when we look at the distribution of our Hispanic and non-Hispanic population, what we found is that 17% of the VCU health system population that has tested positive for COVID-19 identified as Hispanic or Latino. This is very disturbing for us, given that on average about 4% of our population, the general VCU health system population, self-identifies as Hispanic or Latino. This has become especially concerning as we think about what is going on in our OB population. Our leadership in our women's services raised a red flag several months ago and said, we are seeing something that is disturbing and we need to step back and really pay attention. And the data that we have been tracking has shown us that of the women who have delivered babies at VCU Health System, over 1,100 have tested positive for COVID-19. And of those, we performed tests for 1,164. 67 of our moms have tested positive for the virus. But unfortunately, 81% of our COVID positive moms were Latina. 81%. While that is not on par with the percentage of Latina women that we serve and who deliver babies here on an annual basis. So our team began to step back and say, what are some of the drivers? What are some of the factors that we need to be thinking about? So we never want to lose sight of what's going on with our senior population, because again, disproportionately, our seniors have a higher mortality rate in regards to COVID-19. And so we know that there are specific risks that our elderly individuals, especially those who live in congregate facilities and nursing homes, are disproportionately impacted because they're at higher risk. But we've also seen that people of color are disproportionately impacted because of the level of representation in essential work settings. That is, many people of color who are testing positive for COVID-19 work in public-facing jobs, such as in public works, big box and grocery stores, or in industries where teleworking is not an option, such as construction or public transportation, which is increasing their risk for exposure to the virus. And then finally, the Latino population. There is a great deal of work that has been done around what is going on that is driving the statistics around the Latino population. And what we've noted and what has been documented, including by the CDC, is many individuals within the Latino and Hispanic population are contracting COVID-19 as a result of several things, such as the inability to implement social distancing practices due to multiple family members living in single households, concerns regarding remaining at home after exposure to someone with the virus due to the financial impact, and then the mistrust in contact tracing process due to immigration concerns and concerns of being reported to ICE and other governmental entities. We also know that systemic racism is playing a part in what we are seeing in regards to the data or the statistics supporting or related to the Latino and the Hispanic population. And what is systemic racism? It is truly the way policies and practices of organizations or systems advantage some populations while disadvantaging others. And you can especially see this around racial and ethnic groups. It is, as I mentioned earlier, really creating some challenges for the Latino and Hispanic population. And while across the country, our Latino and Hispanic brothers and sisters account for about 18.5% of the US population, they nationally account for about 29% of the COVID-19 cases. So as you can see, at a national level, a state level, and a local level, we are seeing similar trends. So I want to shift very quickly to, if we were to think about how systemic racism plays out in our conversations around equity and equality, and how it is that we are addressing very difficult issues like preventing the spread of COVID-19, then we need to think a little bit differently. And so it's my understanding that this slide was shown in a previous session, but I wanted to share it again just to put this conversation into perspective. And so this is an infographic that was actually developed by a Design and Tech Report last year to help to explain the differences between equality and equity, and then align it with the whole idea of justice. So if we start with the graphic in the top left-hand box, inequality essentially is that one group may have access just because of the way that we are, but there's unequal access to certain commodities or certain things. But the thing that I would ask you to think about is the tree. The tree itself and the way that it has grown up essentially can be viewed as representing systemic racism. It is the way that it has developed over time, such that it leans so that there's more access to the apples for one population, the people in the red, versus the people in the blue. So how would you approach this using an equality lens? How could you address this inequality? Well, you could give everybody a ladder so that they could reach up to the tree in order to grab the apples. The problem that we find is that some individuals, the people in the blue, basically aren't starting out at the same place. That in fact, the systems have grown up and have been built to not provide them equal access. And so if you think about this from a systemic racism perspective, think about access to healthcare. Think about access to health insurance. Think about where people live based on historical redlining practices. So let's get to equity. So if we were really going to make sure that everybody had equal access, what we would do is provide a higher ladder for the people in the blue so that they could also reach the tree or reach the items on the tree. And this is regardless of what's going on from a systemic standpoint. But if we are really to think about justice and how we're addressing systemic issues, we would focus on fixing the tree. And then everyone, given the tools that they have, would have equal access. But given where we are today, and given the work that needs to be done to get to that fourth quadrant, to really, really address justice issues, I would ask you all to just step back and think about equity, because that's where we can make a significant difference with the resources that we have. So I'm going to start with the principle of health equity, which, as I've mentioned, is the idea that everyone has a fair and just opportunity to be as healthy as possible. So if you think about this particular frame that focuses on equity, the question that I would ask is, what can we do? What is it that VCU health system can do to address the principle of health equity? And I would say we can focus on putting more rungs in the ladders for the populations that we serve so that there is equal access to the services. And if you want to put it in just a context, Dr. Paula Braveman, who really is the guru in much of this work, has said that health equity represents our opportunity to bring social justice to health. And that health disparities are important for us to look at because they are the metric that we use to measure progress towards achieving health equity. So when we see decreases in health disparities, it provides us with evidence that we are moving towards greater health equity. And how we move towards greater health equity is by selectively improving the health of those who are economically and socially disadvantaged. And that can be a focus for us. So I will just talk very briefly about the Health Equity Initiative that we've developed here at VCU. And this initiative really was launched several years ago. And we started thinking about how we could look at our core missions related to research, innovation, patient services, and training and education to really focus on addressing health disparities. That was our goal. But then more recently, when we saw what was happening with COVID-19, our team, our steering group said, we really need to focus on COVID-19 because here is a health disparity that we can address if we think about it through our health equity lens. And so we put together work groups or action teams that focused on education, telehealth, and how it is that we are supporting community partners and the health districts or health departments. And we really put a lot of emphasis on focusing on minorities and seniors through our work. So what have we done? In regards to education and information, we are truly focusing activities on supporting people of color and seniors. We've launched educational initiatives in collaboration with our local health department. We've developed focused educational materials for the Latino and Hispanic population, including hosting radio interviews, PSAs, infographics, and really doing significant outreach in the Latino and Hispanic communities. We partnered with the local chambers of commerce to host a webinar for regional businesses, and we are now working on a business owner outreach strategy that is focused on business owners and businesses that serve the Latino and Hispanic community. In regards to our seniors, we've looked at how can we enhance their access to telehealth services. We took a look at where do the seniors live who are patients of VCU health system. And what we identified is there's a cluster in the heart of Richmond, which is also where we have large concentrations of low income communities. And so what have we done? We've worked with the School of Nursing and the Richmond Health and Wellness Program to identify ways to get electronic devices in the hands of our seniors who, number one, have stayed home because of the pandemic, but also are not always as tech savvy. And so switching over to telehealth platforms has not necessarily been a good thing for many of our seniors. The last is how we can support our local health districts or departments and community partners. We've provided personal protective equipment and supplies to one of the local free clinics that needed those things in order to roll out their COVID-19 testing capabilities. We've partnered with the City of Richmond to connect uninsured COVID-19 patients with social support, such as financial assistance and food and housing for quarantine. And then we've partnered with Bon Secours Mercy to purchase over 10,000 masks and supplies such as hand sanitizers and gloves to provide to individuals who were living in group homes and in our Latino and Hispanic communities. This is how we are adding rungs to the ladders to try and go back and address some of those core factors that we know are drivers for health disparities. I will close by sharing a quote that came from the president of our practice plan at MCV Physicians. We were having a conversation in July, and he essentially said, you know, we tend to look at our data, our quality indicators, but as healthcare providers, we truly own the outcomes for our patients. We spend a lot of time and a lot of resources providing quality care and tracking the outcomes associated with it. However, what we often forget is that we have to think more about what happens to our patients when they leave our facilities, when they are in their communities, in their homes, and what are the factors, those 50% of the factors that drive health outcomes that we need to think about, that we might, if we are intentional, have a positive impact on if we're more intentional and we start thinking about health in a more holistic way. And with that, I will pause so that we can open it up for questions. And I'm going to stop sharing my screen so that we can see who is on the webinar.
What do you see as the next community projects for VCU Health related to COVID-19?
It's a great question, Logan. And to be honest, I don't know if we have the luxury of defining it. What we need to continue to do is ask our community partners, ask our patients, ask the stakeholders that are truly being impacted. And so one of the reasons for the work groups And the structure that I showed in an earlier slide is to have that continuous conversation. We have so many resources and so many assets across our university and our health system. We have the opportunity to be responsive, or at least to broker conversations with community organizations to help to address the issues. So I think it is incumbent upon us to be open to what are the needs, and then try to respond by figuring out how we can bring our resources and our talent to the table to address them. So I see there's a question. Are there any language barriers when it comes to addressing the Latino population? And if so, how is VCU addressing this? Thank you, Martina, for asking that question. The answer is yes. There are language barriers, and there are a couple of things that are being done. There are several work groups that have been put together that are focusing on supporting the Latino and Hispanic populations in the community. It has become such a robust conversation that we've had to break down into small work groups, and there's one that is just focused on the development of education, materials, and outreach activities. And that group has been working very closely with the local health departments, Richmond, Henrico, and Chesterfield, to develop information that is available in English and Spanish. However, what we also recognize is that that is not enough, that there are many, many individuals who live in Central Virginia for which Spanish or translating things into Spanish is not good enough, mainly because of the languages that they speak. And so having information in Spanish is not helpful. And so we have looked at what other languages, Mixteco is one. Do we need to start focusing on how we take information and also translate it into several other languages? How can we leverage infographics? And then more importantly, the work that we're really doing right now is, especially with our Latina moms, is how can we identify trusted individuals in the community who can help to provide the information? Because one of the things that was shared with me by one of my colleagues is that the Hispanic community is an oral culture. And so we need to also figure out how we are arming people with the information who can share it with their community members.
But here's a question from Sierra. What do you think some long-term impacts of this pandemic will be on communities of color?
Oh my goodness. So let's start with something that's long-term, but actually shorter or closer than we think, which is vaccines. There is already a concern just around information around the COVID-19 virus that there are so many myths. There are so many myths and misperceptions about this vaccine. About the pandemic. There are folks who don't want to get tested because of myths like, well, when you go to get tested, they're really injecting something in your body, going back to issues of the Tuskegee experiments and things related to whether or not the government is really trying to implant something in your body. And so as we move towards thinking about vaccines and how we are going to get people immunized against the virus, there's the issue of trust and how we begin to build trust in the communities of color. This is a critical factor. How it is that we make information available. I don't know how many of you have gone to the CDC's website to look at information around COVID-19. I've read it and go, this is interesting. I'm not even sure if I completely understand what they're talking about. So how we make information available at a level, a literacy level, that is understood by the individuals who are most impacted. And then another issue we have to think about is how it is that employers understand the guidelines, understand the CDC regulations and state requirements related to interface and interaction with their employees. Lots of educational opportunities there.
Okay, this one I know is near and dear to your heart. What is VCU and VCU Health doing to address disparities in rural catchment areas?
Okay, thank you so much for asking that question. We continue to do work, especially with our community memorial hospital partners, to make sure that they have all of the information that is available that we're pushing out on our website, through the internal channels across the health system. We're also working with community partners who are also reaching into the rural areas, because we realize that COVID does not have geographic boundaries. There's much more work that we need to do, because I must confess to you, I don't understand as much about the rural communities and what some of the needs are as I hope to understand about the immediate geographic regions, but there are continued opportunities, especially as we begin to talk about vaccines. So lots of work to be done.
Okay, now this question is from a new faculty member in ICU, and it's a large social factor that may impact disparities is the looming housing crisis, especially with winter coming. Do we already have some cross-disciplinary work being done for those who want to get involved?
Yes, great question. Lots of work has been done with Homeward, which is the central agency that pulls together homeless services organizations across the region. We work very closely with their executive team, as well as many of the teams from homeless services organizations, to look at the needs for our homeless population in the region. And as you can imagine, homelessness crosses across a spectrum. There are individuals who need urgent services such as shelters. And then there are individuals who are homeless but maybe couch surfing. And so there are different strategies that have to be put into place for the different segments of the homeless population. But one of the things that we have done is work very closely with local social services agencies and local governments and local philanthropic organizations to look at how housing services can be available. Homeward has contracted with local hotels. The city of Richmond has provided funding along with local foundations for individuals who need housing during the pandemic, and especially for those who need to quarantine because they are COVID positive. So we continue to work with those organizations to understand what is available, and then from our perspective, what is it that we can do to enhance the capacity of community organizations. And we actually have something called a community health partnership fund, where we are continuously talking with community organizations about if they need help, how much help, and what is it that VCU Health can contribute to make sure that they can meet the needs.
Thank you. And I would just like to add that in next week's Unlocking Health Equity will be on housing and transportation, so it would be an opportunity to learn more. There was a follow-up question in the chat. It was more about, are there legislative actions we should advocate for? But then it says, seems the imbalance of the effect of COVID-19 is rooting in housing and work issues.
I agree that housing, work, and financial assistance are really, really the core factors. But I have to tell you that I cannot think right at this moment about where it is we could advocate from a policy, or I should say where we can advocate right now, except from a public policy standpoint. And that all of us that are associated with VCU and VCU Health System have a responsibility to continue to identify the issues that we see with the individuals that we are interfacing with on a daily basis, and then to bubble those up through the organization. I am more than happy. You guys can see my email address to be a conduit. If something's popping up and there's a need that you see identified, I am happy to serve as a champion to figure out how we can begin to have the conversation. But there is no one strategy. There's no one strategy because the issues are so broad, the issues are large, and they impact different populations in different ways. And so, again, I'll go back to just my stance. We all have a personal responsibility and a professional responsibility being a part of this university and this academic medical center to really think about where is it that we can identify issues, but then what role can we play in addressing?